Yep. So our next talk is going to be with uh, Nick Dougherty and John Halamka. So one second, let me just move things over. So Nick Dougherty is the managing director of MassChallenge HealthTech, and John Halamka is the president of the Mayo Clinic Health Platform. So I will let you guys take it from there. Thanks.
Awesome. Thank you, Ricky.
And great to be here.
Yeah, really excited. Are we good on the audio?
Yep, you guys sound great. I like the drums and music in the background.
Yeah, exactly. So welcome to the studio. I'm really excited to catch up with John. It's been a while since we've had an opportunity to, so it's a good opportunity for us to connect. So are you in your house in Sherburne, or are you somewhere else?
Well, so this is the Library of Unity Farm Sanctuary, and I of course was supposed to be in Jacksonville, Florida, helping Mayo, Florida, but we as a organization have stopped all domestic and international flights, so it's virtual.
So that was the first thing that I was going to be asking you about. I mean, you've normally you would be on the road all the time, and so I'm curious from a sort of a health system perspective, how are you all thinking about addressing with COVID-19 and working from a digital perspective as a health system that's across the country? How are you currently using digital to coordinate that care?
Well, of course, multifaceted question, which is, at its most prosaic, because Mayo is Rochester, Jacksonville, and Scottsdale, it has long embraced virtual and connected meetings using every imaginable technology to make it feel like you're present. So it's completely natural for the organization to say, well, why would we travel to a meeting anyway? So, let's hope the culture of the world figures that out, that just flying for a 4-hour meeting isn't a great use of time. But more broadly, now that I run the Mayo Clinic Platform, the platform has several components that you can think of as ideally suited to a virtual world, or a world where we need to look at COVID-19. So one platform is the home hospital platform. If we do think that the epidemiological models are correct, and even if the mortality rate is 1%, 2%, 3%, pick your percent, it's still going to overwhelm the healthcare systems worldwide. So we're going to need to think about how to deliver care at a distance. And that means gathering telemetry from the home, virtual teleconsultations, communication, and supply chain. And of course, I haven't been to Target of late, but I hear the supply chain is a big issue. So Mayo has partnered with multiple entrepreneurial groups to think about that delivery of care at a distance, and that's the professionals in the supply chain and the algorithms behind the monitoring. But it also has thought about how you take the data we're gathering and then generate wisdom from it. Because don't we want to think about epidemiological identification that may very well be the exhaust from your EHR or your phone to help us understand a bit? Or wouldn't we want to look at the experience of patients in the past to help us in drug discovery, figuring out what cohorts we should actually target, who is most susceptible, or what are the possible new drug targets? So we're pursuing all of that avenue as well with another entrepreneurial partner. And of course, many of these are in the Boston area.
So can you talk a little bit about how you go about finding some of these entrepreneurs? Because I'm sure that there's other health systems that are listening in and are trying to figure out how do we deal with this epidemic? Like, how do you go about finding these great entrepreneurs, sort of vetting them, sourcing them? I mean, obviously this is new. You got to make quick decisions. So what's your process for going about that?
Well, first choice, look at MassChallenge, right? Because if they don't have the cohort, nobody does. But secondly, if you can't find a MassChallenge participant, then you're doing a fair amount of searching and due diligence to look at least who's in the space. And then so much of what we have to evaluate, some of it's reputation, it's networking, it's talking to all of the colleagues that have served as champions of MassChallenge and really understand what entrepreneurs across this country are doing what. but then also making sure they're aligned. In the case of Mayo Clinic, we worry about reputation. We worry about ethics, data uses, and privacy. So we want to make sure that those organizations we are looking at are very much aligned with the brand and the culture. So ultimately look to accelerators and incubators, look to our network of colleagues, and then make sure there is cultural alignment.
So let's say that there's a company, a startup, or a vendor that thinks that they've got a great solution for this. They're not in an accelerator. They're like, how do they, even if they are an accelerator and they're looking to work with an organization like yours, how do they, I guess, what bar do they need to be at to sort of be enterprise ready? Or what are some of the things that you're looking for so that you say, yes, this solution, this front door that's going to help us identify what patients have coronavirus before they even come into our clinic? How are you evaluating and coaching those companies, or maybe what should a vendor be thinking about to say, hey, I've got this new novel solution, hasn't been tested before. Obviously, COVID-19 is new. How do they become a good partner in that? What are you looking for out of a relationship with an entrepreneur?
So here's what's interesting about Mayo, right? As opposed, I mean, we have all lived in our Harvard and Boston-based environment for many years. Mayo has Mayo Clinic Ventures and Mayo Clinic Business Development baked into the fabric of the organization. So it is incredibly bold, right? That's our 2030 tagline, bold forward, to say, let's find a Series A company. Let's find actually, the earliest of early companies with a great idea. And let's just make sure that what they're doing is obviously safe and high quality. And is there an FDA clearance component? Yes or no? But then we may very well provide the seed funding to move them forward, or provide the data access they need to validate their product. So it's sort of funny that in my, I'm in 8 weeks into Mayo, right? I've had to launch 3 lines of business in association with these entrepreneurs, but also think of the enablers like FDA clearance validation services. And where can we give them ethical de-identified data access so that they can accelerate product development? And Mayo may very well provide funding and an equity stake in those young companies. It's an amazing ecosystem where you're thinking about creating the future by growing it through entrepreneurial spirit.
Sure, and I want to maybe change gears a little bit, because I think we could spend all this time talking about this latest health epidemic, and maybe we'll return back to it in some of the Q&A. So I want to shift over to this massive rule change that just happened. The previous 2 speakers, well, really a lot of the speakers today have been talking about it. And I remember from your time at Beth Israel Lahey before the Mayo, you had both a homegrown health record system. You also were integrating with new health record systems, and you were very involved with FHIR and Project Argonaut. So what I'm curious about, looking at this rule change, and sort of as somebody that's kind of stitched all these things together, for some of the lay people on, like, why do we need things like FHIR, and why do we need things like this rule? How is this going to change the way that you're delivering care as a doctor, but also as a health system?
Well, a couple of angles to that. The first is cultural, right? If you walk into medical records departments in most hospitals in the United States and say, I'd like my lifetime medical record, they'd say single or double-sided, right? 25 cents a page, right? So this cultural change is that the data is now going to be delivered through a JavaScript object notation, FHIR R4 standard API approach. And it's not going to be here's a PDF or here's a piece of paper, go find a third party that can turn this digital. So that's great. The second is the fact that the regulation instantiates a set of standards that are canonical and a set of implementation guides makes it pretty straightforward for folks to comply with it. I think, to be honest, the hardest part is there's been a lot of noise, a lot of discussion of making sure that once the data leaves the protected HIPAA covered entity and then ends up in a container, that there is meaningful consent about what happens to it then. And here's what I slightly worry about. Again, I'm not siding with anybody, but how many of us have read the end user license agreements of the apps we're downloading? Yeah, right. So John Torres, my colleague at Harvard, who specializes in digital psychiatries, downloaded every behavioral health app he could find on Google Play or the App Store and found that 80% of the end user license agreements are sharing your behavioral health data with a third party, right? And that's, I think, a reason to pause, which is it's great, love the standards, love the culture, but let's just not put the burden on the patient to understand where their data is going to flow, make sure it's respectful.
So I guess that to me is something that we've been thinking a lot about within our program too, as we're anticipating this change. We're looking at both the security concerns and also like patient data use. So we're working with the MITRE Corporation on a standard patient data use agreement. I know that Karen is also working on some of those things. I'm curious for you, like what would you like to see in a patient data use agreement, so that it's that the patient knows, or maybe how do we take the burden off of the patient, so that they know where their data is flowing and how it's being used. I'm curious if you have some initial thoughts or recommendations that we could share with our startups or with the broader vendor community.
Well, sure. So when there are certification bodies, and some of these are private companies, I mean, Good Housekeeping seal, for those who are old enough to remember it, it's got a good housekeeping seal. It has made some measure of quality. Well, imagine there was a Karen seal or a MITRE seal or something that says, aha, we have read the end user license agreement and believe that it adheres to these principles and that it is not going to exfiltrate data without your express consent. That would be really helpful.
Yeah, I think that would be a good place to start. And also, even beyond that, saying, hey, we're going to share your data in these other places. I guess what should vendors be preparing still around PHI? Like I'm concerned as a patient, but also as we train these entrepreneurs, we know that we've been trying to get entrepreneurs to be like, you must be this tall to ride, how secure you need to be enterprise ready. Now that a patient can consent to share their data with any number of vendors, do you feel like the bar has just been dropped for security, or do you still feel like it's up there? I know there's a lot of security built into the proposal, but how do you feel about it being practiced in general? And are there things that you often talk with vendors about where they need to get to achieve higher levels of security?
Right. Well, I would say that it seems to me the security bar has been raised, right? That is to say that we're sharing more data with more parties for more purposes and expecting that data to be safe. And so Mayo has taken an approach where we, for example, when we're doing data analytics, everything is de-identified, certified as de-identified, encrypted at rest, passed through a FHIR API inside a Google Cloud container, and the analytics are brought to the Google Cloud container instead of the data being given to the analytics company, right? So we've really had to think long and hard about that.
Yeah, and that's good that you're doing that. And I know that you've had experiences working both sort of in the smaller scale and as well in the much bigger scale. Like, do you feel like sort of the 200, 300 bed hospital, or maybe even like the 100 bed hospital, are they prepared to engage in that way? And where should they be going to get access to some of this digital health innovation? I mean, I look at our organizers for today and One Up Health and their ability to aggregate data in meaningful ways. Like, how are you recommending people get up to speed that maybe don't have the engineering staff or the venture team to be able to bring some of these solutions in?
Well, as you know, I've worked in multiple provider organizations. And those provider organizations, even the most sophisticated ones, might have a dozen or 2 dozen people thinking about security. Ask yourself, Google, Amazon, Microsoft, how many security people do they have? Thousands upon thousands. Start to ask yourself this question, which is, when do you recognize that you need to collaborate with these external vendor partners? So it could be big tech, right, for cloud storage and compute, or it could be smaller companies that specialize in this area, because they can actually do a better job than your internal staff. And I think, I've been on a couple of virtual presentations today, as you might expect. We're having this discussion over and over. The role of the CIO is moving from a provision of infrastructure and security to the selection and orchestration of the vendor partners who are actually doing it in a better way.
Yeah, absolutely. And so I think, when you've had some experiences where they've done sort of work in a better way, and I'd love to move on from the conversation around. Actually, I'll ask you one more question about the regulation. Like, is there anything in this new rule that you feel like people aren't talking about, that you wish people were talking about? Is there sort of one key takeaway that you want to make sure that every vendor or provider or payer is really paying attention to?
Well, I think one slight concern, and I'm sure the folks at Da Vinci are going to figure this out, is I've worked in the payer community for 30 years, right? So that is with NEHIN and other things. And many of the underlying transactional systems in the payer community aren't exactly API enabled, right? They're COBOL mainframes that were created by Ross Perot. And so I worry, as Anish told us, the providers have had a bit of runway. We've had meaningful use through multiple stages. We've been signaling about these APIs for years. I think they're probably going to be okay. But are the payer underlying transactional systems going to be able to support the level of interoperability? I think we need to watch that one carefully.
Sure. So I want to talk a little bit about some of the entrepreneurial relationships that you've had over the years. And I know that you've made this sort of transformative impact on many entrepreneurs, frankly, even countries, with some of the work that you've done. I would love to sort of get in and share some of those insights that you've had over the years and working with some of the entrepreneurial community. You mentioned sort of at a high level what the Mayo Clinic is doing, but I also think that we need more people like John in these environments where we have to solve big problems and take big leaps of faith and really use our positions to make an impact. And so I'd love to hear sort of your, one, I'd like to learn a little bit more about your philosophy as a mentor. And I want to start with that. So how do you, as an individual, within these large organizations, what's your approach to thinking about supporting and working with entrepreneurs and helping them get their solutions off the ground? Because if nobody takes that initial leap of faith, they're not able to get their solutions into the market.
Well, sure. We'll solve a real problem that has a sense of urgency that people will find value in such a solution. So let me give you an example. 6 a.m. this morning, I'm on the phone with 3 chiefs at the Mayo Clinic, and the topic was, how do I restore joy to your practice? And they said, well, our notes, of course, take a very long time to write. If there was a product that could help me create all the documentation I need in a much more rapid way by drawing on external data sources, machine learning, templates, ambient listening, all this stuff, that would be great. Oh, and I have another problem. I can't navigate all this data that's coming in from everywhere. I need something that's going to sift the signal from the noise, show me just what I need to know. It's personalizable to my specialty or the patient in front of me. Or wouldn't it be best if I could do my ordering in a way that was based on a best practice of thousands of patients like this in the past, and the care plans were more automated? I only tell you that because these are the sorts of things. I was just told at 6 a.m. this morning if there was a product, they would buy it.
And I bet there's a bunch of people emailing you right now.
Yeah, the chat's already coming up about all the fire-enabled products that already do all these things. Yeah. So the point being is that when you meet with the entrepreneurs, I meet with entrepreneurs who say, and we're going to develop a way to connect your Fitbit to your Twitter feed so you can have a social networking for heart rate sharing. Woohoo!
Just because it works doesn't mean that it should be a product or a company. And I think that to me is something that we observe and we talk about with a lot of our entrepreneurs. And I think you hit the nail on the head with that you have to solve a real problem. And I think to dig like a layer deeper below that in terms of how we define the real problem, I think you can talk about it. It's like, are these problems that people are talking about that are keeping them up at night, that are that they're assigning budget to, that they're looking to make decisions on? Yes, sometimes there are problems that organizations have that they're not aware of yet, and you can make them aware of it. But still, I think that you hit the nail on the head. You got to be able to identify a problem, and you've done such a good job working with a lot of our entrepreneurs on helping them sort of find that underlying fundamental problem so that they can go after and ultimately attack it. I think, there's a couple examples. I'm curious, would you mind sharing, some stories of some entrepreneurs that you've met with where, maybe it started where they may not have been fully aligned and sort of how you sort of coach and navigated them through that process to, ultimately help them get off the ground? I know that there's at least a few examples. So I'm curious if you want to share one or two.
Well, sure. So what you always ask is to influence a physician, you either ensure they are paid more, ensure they have a better quality of practice life, or help them avoid public embarrassment, like a bad quality score or a malpractice assertion. So when somebody pitches an idea, I say, well, which of the three does your idea apply to? I know, let's pivot your model, pivot your pitch deck. So it's just narrowly focused on one of those three. And then we'll figure out, who it is who will be the champion. And then the champion will ultimately make sure it gets pushed through IT or the CFO or wherever. So going to the CIO and expecting them to just embrace an innovation, not likely to happen, right? Has to start with a passionate champion based on having created influence for them in one of those three dimensions, likely.
Absolutely. So Ricky, I know that we only have a limited amount of time left with John. I know you got to run in a few minutes here. So do we have any questions from the live chat?
Yes, so we do. So one for John. How has fire data been transmitted between organizations? Have there been ways to scramble or anonymize the data from the source and then reassemble it, when it's gotten to the destination, apart from, I guess, normal kind of encryption that you would do online?
Yeah, everyone, we're getting an echo there, says, one will want to ensure that data is encrypted from end to end while in motion, while in rest. And that's pretty straightforward. But to your point, fire to me, I'll give you, a couple of workflows. You've got a fire-enabled API that sends the data to HealthKit. HealthKit then is capable of sending that data through an app to a third party. We've done stuff like that. Obviously, what you're doing at OneUp Health is creating another mechanism by which you, acting as an agent, can pull that data and then share it out with third parties, and guaranteeing that end-to-end security. And obviously that architecture is appealing too. I haven't yet seen provider to provider direct fire-based exchanges to scale. And so they're involving some kind of intermediary that's dealing with the impedance mismatch. You got Fire R2 over here and Fire R3 over there and Fire R4 planned over there. Oh, and you even got HL7 V2. So I think broad answer to your question is, at the moment, having an API orchestration layer between two trading partners probably works best.
Makes sense. And another question from Lily: how do you incentivize hospitals, especially smaller organizations that may not have the full capacity of Mayo Clinic, to implement FHIR and also build on top of this architecture?
Well, either the product is so cool you want it, or government regulation requires you have it. Right? And so I think, as we've seen in these final rules from ONC and CMS, it's very clear that small organizations will have to comply. And sure, there are 8 exceptions, but they're going to have to comply. So what you're going to see is this rich ecosystem evolve, where every organization is going to have to find a partner so they comply with the regulations. I think the motivation is pretty clear.
I also want to share a little bit on that. So we work with the American Medical Association. They've been doing some research on digital health ROI. And a lot of what you need to be able to demonstrate is, like, how are you either going to generate revenue or pull cost out of the system? So you can't just solve a clinical need. You also need to address some kind of financial need. And that's especially true in these smaller organizations. A lot of these health systems have a narrow margin. So you need to be able to demonstrate that you can bring some kind of financial ROI back to that institution.
Right. And I think to Nick's point, I mean, he knows, because these have been MassChallenge spinouts where they go to an organization and say, I'm going to offer you a service for free that's going to reduce 4 FTEs and take out 10% of your supply chain costs. They say, how fast can you deliver it? Oh, I need a FHIR API. We'll get you the FHIR API.
Right. Exactly. So if you come with the solution to a real problem and you can quantify it and it can be measured, then they will get stuff out of the way for you. So if you're finding that there's roadblocks that are being put in front of you and they're not moving forward, maybe you haven't found the right solution yet. And oftentimes we find that's the case. It's a nice way of saying no.
So bureaucracies are masters of the infinite delay. Let's form a subcommittee that'll assign a task force that'll create a white paper to study the efficacy of this solution, i.e., no.
Pretty much. Do we have any other questions for John before we let him hop off here?
Yeah, just one last one. So a lot of times selling to health systems is a very long, time-consuming process, and security is a big chunk of that. And every health system and organization has their own security protocols that they need to check boxes off of and reviews. What are your suggestions on how that piece of the equation can be streamlined, and how would you work with others like MassChallenge or other organizations to help that move faster?
Sure. There are multiple certification bodies and approaches to looking at the security, both your technical and process security, whether that's NIST 800, COBIT, ITIL, HITRUST. I recognize that an entrepreneur is likely not going to be able to afford to go out to one of these more expensive certifications, but to say, yes, we have decided we're going to embrace NIST 800, and here are the policies and procedures we've put in place, that will bring great comfort to any customer. What Mayo has done to accelerate the process that you've just described, we've created a new, we'll call it one table entry point, where compliance and legal and IT and security are all sitting at one table. You produce one artifact, you do one presentation, it is just approved or denied right then at the one table. We had to do that.
Yeah, and I'll make one comment or plug for that. If you go to together.health, we have a standard security assessment that we've done by collecting a bunch of risk assessments that we gathered from across the industry. It's an awesome opportunity for entrepreneurs or vendors to see what are the most common controls that health systems are looking to build towards. And then I would say that a lot of it is built off of NIST 853. So definitely take a look at it. There are solutions out there. Thank you, OneUp team, for including us. And thank you, John, for joining us today.
Well, absolutely. What a great opportunity to get together with my friends. Come out to Rochester sometime.